Next report will be delivered by Sergey Yakovlev, and he will talk about complications after treatment of aneurysms.
Dear Chairman, dear colleagues, let's look at the by-side effects that we face treating brain aneurysms recently, especially based on the experience of our clinic. Why I'd like to discuss these issues? Because there are relatively simple cases treated locally, and with every year we'll admit patients with more complex cases. We have to start with defining the factors which underlie the indication to endovascular treatment. I'm not going to go into too many details, but these are the anatomic aneurysm parameter, clots, and so on. Localization, anterior circulations. Here, there is also relations with open surgery. And in our clinic, very often we discuss those cases together with the previous speaker's clinic. Of course, there are also the important point whether these are major vessels or distal periphery vessels. This is also very important. The period of aneurysm exposure is impossible because the ruptured aneurysms require emergency surgery. For example, with direct discussion with open surgeon, unruptured aneurysms form a special group that can be asymptomatic as well as symptomatic. Most often, these are large, gigantic aneurysms which have a compression impact upon cerebral structures, causing certain symptomatics. The clinical status of a patient is also important. Comorbidities, for example, it's unlikely that you decided to operate the patients with chronic and even acute renal deficiency, and neurological status is important. An essential role in the success of a surgery is on the tools that you use for approach to a particular vascular bed segment. It's essential to use vascular guide catheters, which very soft impact upon the inner parts of the major vessels, the guide catheters. Recently, distal approach catheters are in place. They make access to intracranial aneurysm much easier. And microcatheters, the entire structure of those catheters have been modified radically throughout time in order to enable the most adequate access to the brain vessels. Also essential in comparison with other localization to have high-pressure washing system. These are such polymer sacks that enable ongoing washing of neurotools. Coils are also used. With regard to complications, of course, every X-ray operating room should be stocked with particular devices to be able to liquidate clots, displayed coils, and so on and so forth. To this purpose, there are various retrievers and traps, removal loops, and so on. So far, around 3,000 aneurysms have been operated. In 1995, microcoils appeared in Russia. And in our clinic, We mostly receive patients on a regular basis, but we do have acute patients, about 10%. And the age range is also pretty considerable. Regarding the treatment, we look at the acute or cold period of hemorrhaging, bleeding in anamnesis. We use microcoils. What are the advantages in aneurysm occlusion, small and medium one? Here, the occlusion effects is immediate. We fully enable prophylaxis of repeated hemorrhaging. As for stand assistance, the body neck indications are becoming obsolete, and we increase the indications for aneurysm of broad localizations. And here again, there is an effect of immediate occlusion. However, it's not always possible to cure aneurysm using these techniques. As a result, implants and flow diverters are being developed that can be used in any localization and size. In our opinion, very rarely they can be used in the acute period because there should be certain preparation, double disaggregant therapy. The effect of flow diverters require some waiting period, at least 6 months, and a patient should take such drugs for at least 6 months. However, those aneurysms that earlier were considered unoperable, like giant aneurysm and aneurysms with clots, the most optimal treatment would be this technique. Deconstructive surgeries. Before microcoil was developed, occlusive balloon catheters were used. So pretty extensive experience is accumulated, and the followers of those methods, those who started doing them, Professor Lazarev, who is present here, deconstructive procedures with time also become obsolete, and recently, in the past few years, when we look at the statistics, the aneurysm procedures, 5 to 6% only in the past 5 years. The figure was much higher prior to this. Reconstructive procedures, we used stand assistance, balloon assistance, combined assistance. We prefer stand assistance mostly in the anterior circulation. Here you have seen the total number in the historic period, 15%, mostly in the caverna segment, 90%, and if there is a deficient collateral blood supply in the hemisphere, extracranial microvessel anastomosis is necessary, on average, once or twice a year. Here you see the outcome: transient ruptures about 5%, persistent 5%, and mortality less than 3%. In the posterior circulations, of course, the results are much worse due to the anatomy. Compact vessels in the posterior cranial fossa, absence of anastomosis between the major branches, and especially in the initial period in the 90s, spinal arteries occlusions were used, particularly occlusions of two spinal arteries. And of course, the adverse outcome is much more frequent. This is the total percentage of complications, mortality around 2%. Complications can be broken down into ischemic, hemorrhagic, and inflammatory. They can be clinically significant, related to transitory neurological disorders of blood circulation and neurological deficiency. And mortality. Typically, complications lead to mortality in this group of patients. Some complications are of technical nature when coiled stents are implanted, and these changes, the hemodynamics, are asymptomatic due to the collateral. What are the preconditions for complications? First of all, anatomy. When there is tortuosity of brachiocephalic arteries, kinking, loops, sections in extra and cranial vessels, fusiforms, aneurysm, when across the entire wall and the implanted stents is basically weighted. Clots are very important. If you attempt to achieve occlusions with microcoils and there are clots, there is a danger of clots migrated from the aneurysm's lumen to distal bed, and also spasms can deteriorate. Aneurysms in the posterior circulation are also quite complicated, and there are issues with revascularizations. Tactical preconditions. First of all, non-compliance with anti-thrombotic protocol. Recently, we pay a lot of attention to this because we need to understand who is the patient and will he or she be adequate taking anticoagulants in stent assisting operations or after the flow stent is installed. If the patient doesn't take such drugs, it can result in thrombosis of a particular vessel segment where the stent is installed and it's ischemic stroke. So if a patient or his relatives say that they have no money to buy anticoagulants and there is no way to control whether these drugs are taken, there is no other methods, then perhaps that is not an option. And these technical tactics of treating multiple aneurysms. Here, the main efforts should be directed to expose the aneurysms which lead to subarachnoid or parameters hemorrhaging. And if you see an aneurysm without bleeding, then postoperatively or in the follow-up period, you can get repeated bleeding, and there are special techniques, MRI techniques, which enables to identify hemosiderin close to in the proximity of particular aneurysms and to determine whether this aneurysm is responsible for primary bleeding. So treatment should be started with such aneurysms. Next, technical issues. Regardless of how nicely the manufacturers advertise their tools, obviously there are some failures, and everyone knows that the process cannot be completely automated, and most microcoils are assembled manually, so there is a human factor involved. First of all, it's the behavior of the microspiral. Not very often, but it can be a self-induced detachment of a coil inside the catheter. In reverse traction, the spiral can be extended due to rupture of a spiral polymer thread inside. So the spirals getting extended, and you can pull it nearly to the femoral area. The tip of the guide wire can be detached, or stand doesn't fully open. Displacement of stand during implanting is also a mistake that we can make. Anyway, we should strictly follow the instructions and shouldn't use the tools, for example, coronary wires, for brain embolizations. We shouldn't use those tools that are not designed for brain work. Intraoperational aneurysm rupture, it can happen arbitrarily, like self-induced rupture at the initial stage of the operation. More frequently, perforation of an aneurysm wall can happen due to serious mistakes in manipulating microcoils or virus. So you should be very careful looking how it gets out from the catheter, how it rolls in the aneurysmal lumen. So you need to be very careful to avoid any mistakes. If there is an intraoperational rupture, the only measure that can help is a fast ending of bleeding. You can achieve it through fast putting microcoils in the aneurysmal lumen with a maximum careful manipulations. Otherwise, you have to occlude the aneurysm together with the bearing vessels, which is more dangerous in terms of neurological disorders, especially if it's higher than the Willisum circle. Here you see patients, female, 43 years old, aneurysms of ICA, occlusion of aneurysm on the right with microcoils. On the left, there was aneurysm rupture, and we could do nothing else but do the occlusion in the carotid artery. Sometimes there are such cases, a very complex configuration, multi-chamber aneurysm on the basilar artery, occlusion with a microcoil. Everything seems to be okay. There were no issues related to aneurysm perforation. But anyway, in a post-operational period, in 6 hours, you can see massive subarachnoid bleeding on CT. It's hard to say what caused such situation. Looks like all aneurysms are occluded, but still not everything is clear. Perhaps in the neck area there was a rupture, which ultimately led to severe complications. However, we managed to put the situation under control, and we introduced the blocker, 2 procedures which enabled us to control the spasm and stabilize the situation. During the 2nd week, the patient was discharged 16 days after in satisfactory conditions. Here's a phenomenal double complications. This is an aneurysm of an ophthalmic segment, superior locations of ICA. In the attempt to install the first coil, these occlusion on M1 segment of the MCA. At that time, we didn't have retrievers that we have now, so the microcatheter was transferred to MCA. 200,000 units of urokinase were introduced locally, which partially recanalized the MCA. After the first coil and installed, rupture happened. You can see that the material was distributed, but fast tamponade stopped the bleeding, and gradually the patients recovered with minimum neurological deficiency. Thromboembolic complications, already mentioned, the clots migrate from aneurysm at the time of catheterization and coil introduction. More often, however, we see clot migrations when clots are formed on an endovascular tool, guide catheter, due to poor or absence of washing, and also spasms, manipulation, angiospasm can be responsible. Prophylactics include mandatory use of washing system and heparin. Until recently, IST was used to control the heparin action. Recently, however, we've been moving away from this, and this dosage, 5,000, proved to be efficient. Other treatments include local thrombolysis, mechanical thromboextractions, using the distal approach catheter, and also treating thromboaspirations with calcium canal blockers. Here are multiple aneurysm. Here we have embolia with guide catheter, one occlusion in MCA. That is the moment when stent retrievers already were available, and it was possible to remove the thromb. Here we have a persistent recanalization effect. Paranoid aneurysm in left ICA. Localization was achieved. Here, occlusion was achieved, and here we see clot and a wall which was liquidated using local thrombolysis. As for migration to the vessel lumen, everyone has faced it. This is the problem of the so-called last coil, when the size wasn't selected properly and the coils detached on its own from the pusher. Here, the issue, especially for young surgeons, unexperienced surgeons, is their desire to achieve total occlusion. So at some point, you should take a rest, and if you have doubt with regard to full aneurysm occlusion, you can check various resources like angiocalc.com and recalculate the degree of the occlusion you've achieved. Regarding treatment, for example, you can put pressure and press a particular segment with a stent to the wall. If, however, a coil of a pretty long fragment is in the bearing vessels, then you can attempt to use a retriever and catch it. Here is a case with the spinal artery aneurysm, distal, posterior, parabellum, everything was good until the coil detached in the microcatheter. An attempt to catch it were not successful, so we had to use a coil for spinal occlusion. Luckily, the opposite spinal artery fully performed the functions for blood supplies of cranial fossil. Anyway, we see an ischemic focus. Here you see another complications. The stent was implanted, and the mistake that we made, we used a microguide wire with a curved tip, and in catheterizations, it basically hooked one of the stent cells, and this is how we had to pull it down and then catch at the extracranial level of the carotid artery with a special retriever. But ultimately, we even managed to remove it from the vessel lumen through a guide catheter. And interestingly, no spasm was developed. A second stent was implanted, and the total occlusion of the aneurysm was achieved. Another complicated case, stent assistance, pretty complex pear-shaped aneurysm. Here, we wanted to go for stent assistance, and at the time of stent implanted, we didn't calculate the length correctly, and it was displaced vertically towards the aneurysm bottom. Luckily, we managed to retrieve it and implant a stent diverter stent. With control angiography, we saw narrowing at the end of the stent, and there is no branch on MCA. So what we had to do, we had to perform thrombus extractions with solitaire, and then regarding 150 units of thrombolytics and establish blood supplied. Large giant aneurysm fall for lion's share, and so far we have around 900 patients. Pretty good, beautiful technologies, but still there are issues that we can discuss. Currently, we used stents from various manufacturers, mostly pipeline, to prevent complications related to under-opening or migration of a stent. Changing the size of a bearing vessels, the lesion extensions are important. To this end, we can use the 3D mode to build a model, a virtual model, measure the proximal and distal vessel diameters, and select an optimal stent position. And here in 3D roadmap, we can implant successfully. Controlled after implanting flow diverter is mandatory. Typically, because X-ray control is pretty poor, CT is necessary to clearly understand the position and degree of stent opening. Here, I think the stent size was not chosen correctly, its diameter, although brachiocephalic arteries are very tortuous here. And there is an attempt to implant a stent when we noticed that there is no stent opening, so we had to retrieve it using a micro loop. We cut a proximal tip and then pulled it out from the carotid artery. Unfortunately, dissection developed and the carotid artery was not preserved. Luckily, communicating arteries are quite good. So this is what we also have to face, and unfortunately, unlike the first emotions that finally a new device is found and we can go against the radical and operable aneurysm, unfortunately, giant aneurysm means complicated case, rupture of aneurysm. It seems that the stent installed, hemodynamics is changed, but still a number of patients with such a complex pathology, in spite of anti-aggregant therapy, there is a wave-type trauma development that crosses the aneurysm wall, which by itself is pretty thin, and it leads to rupture. Also, early post-operational ruptures lead to patients' deaths. A crucial follow-up period is from 1 to 3 months. When rupture of such aneurysms is possible, what to do against it? It's a big issue, and it's still not resolved. There are some recommendations to use hormonal drugs, and other drugs which can block inflammation of vessel walls against the fast clotting, but it is not very efficient, especially in our experience, because hormones and other drugs, PVS, do not prevent rupture fully. What we all agree that practically total coil occlusions in such aneurysm is necessary. But just imagine how many coils should be implanted. It's a huge, it's like a warehouse of a large cardiac center. So there are issues, of course. Plus, if we fill it in with coils, we understand in advance there'll be no voluminous impact. And this is a pretty rare inflammatory complications. Paraclinoid occlusion, here using aneurysms, coil occlusions, and finally there is an abscess in the subcortical ganglia. But luckily, regress was achieved with therapy. Finally, I'd like to emphasize that only neuroendovascular tools and high-pressure washing systems should be used only. It is necessary to have stocked tools in the operation theater that we discussed, like stent retrievers and so on. In case of any complications, the surgeons should continue fighting, should call for more experienced colleagues, and together reach the most optimal decisions, which in my opinion is always there. And finally, let me show you complications that initially at the first glance seems to be about nothing. One of the younger doctors attempted to catheterize the aortic arch, and the catheter basically formed like a node. What did we do? We put a rigid catheter in the opposite femoral artery, and we were able to retrieve the catheter. Thank you for your attention.